Every Monday at 11 a.m., learn about how the Queen Elizabeth Hospital works and how to make it work for you on Q. From the A&E to the ICU, NCDs to CPR. The QEH Pulse radio show is about your hospital and your health. Join communications specialist Shane Seeley, patient relations manager Dr. Rhea Corbin-Hart, and specially invited medical professionals as they provide vital health information, answer your questions, and address your concerns live. The QEH Pulse radio show, every Monday from 11 a.m. until noon on Q 100.7 FM. The QEH connects with you on Q.
A pleasant good morning and welcome to the second episode of the Pulse Radio Show. I am Shane Seeley, Communications Specialist with the Queen Elizabeth Hospital. I always have my lovely sidekick, co-host and partner alongside me.
Good morning,
I would be Batman and you would be Robin.
Whatever you want me to be. Whatever
course.
You want me to be. Shane,
that's Dr. Rhea
sure.
Corbin-Hart, our patient relations manager. And this morning, we're putting the spotlight on everyone's favorite topic relating to the Queen Elizabeth Hospital, the Accident and Emergency Department. So we know you will have your questions, and after we set the scene, we will spend the first 10 minutes or so just letting you know a bit more about everything that happens in the Accident and Emergency Department. And then, of course, we will welcome your calls. And you can always call us at 434-1007 or 434-1070 after we paint the picture of the Accident and Emergency Department at your Queen Elizabeth Hospital. Dr. Corbin-Hart, we always hear people talking about A&E. You've worked there as well. You've been a part of that. And we must also introduce, we have the head of the department, consultant Dr. Anne-Marie Cruickshank. She is a very familiar face in the Accident and Emergency Department, spends a lot of time treating many patients that come through our doors at those times when things are manageable, and also at those times when there is a surge. And she would call me and say, Shane, we need to send out information to the public to let them know things are getting a bit busy
so they can prepare
exactly
what with their comforts and so on.
And I always say there's nothing wrong with more information, because we do it especially during the hurricane season. We send out advance notice to let people know what to expect.
Hurricanes are coming, how to get prepared, and that's the same thing we need for accident and emergency.
I say no more.
Definitely.
We need to get the messages out to the public, and that's what we will be doing.
That's what we're here for today
on the Pulse Radio Show.
Indeed. So I'm going to try to give a synopsis on the Accident and Emergency Department. Now, we always speak about A&E, or casualty as some persons call it, and we kind of speak about it on its own. But I think it's important for us to note from the beginning that the Accident and Emergency is part of an entire healthcare system. We speak about primary, secondary, and tertiary healthcare. The Accident and Emergency is part of the hospital, which is tertiary healthcare. What that means is that there's steps prior to come into the hospital or to accident and emergency. So your regular family doctor or your GP or your polyclinic doctor, that is regarded as primary care. You have secondary care, where you're a bit more serious than your regular follow-up cough and cold, hypertension, diabetes follow-up. That's secondary care. We have a lot of private secondary care facilities across the island. The hospital then is the culmination. When you've passed from primary care to secondary care to tertiary care, you're quite ill, you're quite serious, you need prolonged interventions, prolonged treatments, specialized interventions for your health care.
And just a reminder that the QH Pulse Radio Show is brought to you with the compliments of MedSafe Medical Supplies Limited. We'll tell you a lot more about them as we take you through the morning.
Thank you to MedSafe. So we've touched on primary, secondary, and tertiary care. That's just an introduction. The next part I want to talk about is the fact that the accident and emergency, though it is not regarded as a ward, and it is not a ward, but it is a place where you get treatment and reassessment and investigation. And these are things that can take time. For example, sometimes, your it's not like primary care where you go in for an illness and you may get a prescription to treat your illness. The doctors in accident and emergency are trying to figure out, do we need to admit you to hospital, or can this be adequately treated at home? If I do an intervention, may it be IV fluid or drips as Bajan speak of, will you get better enough that I can allow you to go home and continue to recuperate at home with some medications that I think are necessary for your condition? Or do you need to be admitted? So these are things that take time. They may give one type of intervention, give it a few hours to see how your body responds to it before they make a final decision. They may do test A. Based on the results of test A, they may need to go on to test B. They do a myriad of things that physically take time. So we're going to discuss today with the assistance of Dr. Cruickshank about what are the steps. So I'll give the broad steps, and then we'll get into a bit of detail on each one. You always hear about triage. You're obviously seen by the A&E doctor. You can get tests if they're necessary for your condition. You can get reviewed by your doctor, and then your doctor decides what should happen to you. Should you be discharged or referred for a special opinion or referred for admission? And your doctor then does the referral. The specialty team comes to see you if you are referred, and once they agree that you need admission, you are then admitted to the ward pending availability of a bed. So I'm going to ask Dr. Cruickshank at this time to share with us a little bit about triage. What's the purpose? What's the components? Things like that, so that we can understand better about the triage process.
But before we get into those specifics, Dr. Cruickshank, welcome to the Q 100.7 CBC radio, but more importantly to the Pulse radio show. I want you first to start off with a synopsis for yourself. You've been in charge of the department for close to 2 years now?
Yes, this is my second year.
This is your second year. Yeah. What has it been like at the head of A&E?
It's been very challenging, but it's been also very rewarding to think that we are now in the new A&E, as I call it, and plus the expansion has been added to the renovated or new A&E. So we've moved into that about a month or so ago, and it's been rewarding and uplifting to see all the new changes and the space that we now have that we can spread out a little bit more, because as you would know, Shane and Dr. Ria, we were in 3 stories before, and it was very congested.
It was.
So now being in 18,000 square feet, we are now spread better, and you can see the staff feel more comfortable as we get on with the business of day to day.
And one other thing, last week, Ria, we started it and we can't leave it out. Those stats for the accident and emergency department. Dr. Cruickshank comes on our morning brief and normally brings us up to speed with what's happening, what's the state of play in the accident and emergency department. What was it like over the last 24 hours coming into this morning?
Over the weekend it was quite busy. We were nearing a patient surge. But this morning, there are about probably 25 patients at 8 o'clock waiting to be seen.
25 patients?
Yes, we do have enough staff. We think that we can manage that. We're not at surge capacity at the moment, so we're hoping that the day runs smoothly, and that will be on top of the patients waiting to be seen.
And how many persons were seen in the last 24 hours? I should interject here. I think I mentioned it last week, but seen encompasses so much. Seen encompasses talking to the patient, hearing what symptoms they're having, examining the patient from head to toe where necessary, doing investigations, waiting for them to come back, starting management, putting up lines, putting up drips, so many things, so many procedures, putting in catheters. You literally go from putting in a catheter on one patient to reducing a broken hand on another patient to assisting a lady having an abortion within 30 minutes. That's what seen means. How many patients had all of that done in the last 24 hours?
So reporting for the 9th of June, which was yesterday, we saw about 66 patients yesterday. 66, yes.
Saw, treated, managed, investigated.
Yes.
referred,
It's a lot.
discharged,
Yeah.
spoke to relatives, all of
Yes,
that,
but we can range up to the 80s
into the 80s.
when we have enough staff. We can
That
go up
is
to the 80s and a little less than
impressive.
100 when we're doing good.
Yes.
It's a lot. And before we get into further details then on the triage system, because as Dr. Corbin Hart mentioned, everyone wants to know how we manage patients,
Yeah.
how we try to be more efficient in the management of patients. Let's get that first caller in. Someone was waiting on the line. Welcome to the Pulse Radio Show, caller. What's your question or comment for us? Good morning, caller. Caller, are you there?
Yeah, I still.
I can't hear you now. Can't hear you louder.
Yes. You can hear me?
Yes, I
Yes,
can.
we're hearing
Good
you.
morning. Welcome to the Pulse
good
Radio
morning.
Show.
Yeah, I was just calling to say that with what the first doctor was saying about primary care and like your outside doctor care and so on. Like when you do take, say, I know I went and spent out a lot of money at a certain facility, over $1,000 in change. And when by now I still had to end up going to QEH and sitting down in the accident place, right?
Right.
And for a certain guy that don't work there no more, because he's supposed to be a heart patient, has not for him, and the grace of the Almighty God, I won't be here this morning talking to you all. So what she's saying is about all of this, yeah, I understand it, I get it, I know that the world changing, everything changing, everybody changing, and trying to do the best what we think is going forward. But as you all say about this primary care and go to your private doctors and check and stuff, you do go, and when it boils down, you got to go to the QEH, you know that?
And that's why we are there. We are there when the
Yeah,
private medical
yeah,
physicians
yeah.
refer you to the Queen Elizabeth Hospital, and we'll get more into that
For
and
sure.
that process, because that's just the beginning. So that's why we have the Pulse Radio Show, to explain
Yes,
to callers
that's
like
great.
yourself how the system works now, so that when you engage with us, you can better understand why you may have to wait, and we are going to get into that as
Yeah.
well. So many things to get into,
would
caller.
rather- why that as you all are saying, yes, I can live with that. Why when you can't step with the well, that ain't gonna come in time. I know that everything takes time.
Everything is a work in progress, and
Yeah, but
and
I'm talking about the polyclinics, and one or two of them, like in certain places, will open a little later then and put some more qualified people in there to help step up this thing with accident emergency call. You ain't there, and it was not nice. And again, before you go, why when I got the people that take their families there outside sitting down under the tree in the sun, the rain, the rats, the everybody running about over there. When will we get some place to sit down that if you don't want to leave the hospital and leave your loved one, but you ain't inside by accident and emergency, but at least some place comfortable that you could be sheltering out the elements. How about that?
yes,
Yeah.
and there are places that you can be, which are out of, as you say, outside of the elements, not outside in the elements, but you would be.
When I went there, Shane, I were out in the elements.
When did you go there?
There again. I went there about last month, and
Right.
we had to sit down outside the gate there, so by the little benches over there where the people themselves. And you all then ain't nothing there yet, and the guard telling you about which and I know you can't go in where the stuff going on now and stuff. But when the rain come down, where you gonna go? When
Right,
it is
okay.
sun, where you gonna go? When all sorts of things. I see some rats running about out there. Cause
Right.
it's actually 12 o'clock out there,
So,
1 o'clock
caller-
waiting with my granddaughter.
I hope your granddaughter is better now.
No, she is not, because then that ain't for her to bring here, because she have a real serious case there with her
Understandable.
business, right?
Yeah, you don't have to say her business on the
Ah,
on the
that
air.
would never happen.
But during our renovation, we were under a reduction of visiting, given the fact that we were in a smaller space, and we wanted to ensure that should there be emergencies and you need to move patients quickly, that there's enough space to do that. So given it was a
I
smaller
understand
space
all
during
that.
that renovation, unfortunately we were not able to have as many visitors inside as usual.
I know all that.
Now
but
that we're in the
one
expanded
that Shane-
space,
Caller, let Dr. Caller.
Fix.
Caller, let Dr. Corbin Hart finish her statement. You ask a question, you're going to get the answer. Go ahead, Dr.
Now
Corbin
that we're in
Hart.
the expanded space, our relatives have two places that they can utilize. We have a garden with picnic benches, nice foliage, shrubs, and so on for those persons who wish to be outside of the air condition, because our outer waiting area is air conditioned now. Persons can wait there.
A lot more comfortable.
Yeah, some people say they don't want to be in AC. And then persons also wait either at the bedside, dependent on space, or persons wait in the outer waiting area as well, where other patients are, but they can wait there as well, and
With
they
their
can
loved
come
ones.
in. They can either wait there with their loved one if the loved one is in the outer waiting area, or if the loved one is inside, they can come out, take a break, have something to eat, sit, and then come back in once it is a good time and that the patient isn't having a procedure done and so on.
And let me add to that, caller, on the heels of what Dr. Corbin Hart just mentioned. When family, when one of your loved ones is sick, everyone wants to come down to the accident and emergency department to, just be there and lend that support
Yeah.
to until that relative is better or they are on the up and up. But what we don't want going forward, and I know this is a cultural thing that we do, you do not need every single person in the family to be down there at that time. One relative, maybe two, is enough to spend some time there to make sure that your relative is getting through, and then we can accommodate. You don't need 10 and 20 people outside the accident and emergency department.
And we do
or
ask
in the area.
for one person at the bedside, again, to reduce congestion and
Indeed.
Also to try to have a little bit of privacy at least, for the patients who are there. And what I encourage persons to do is that you have one person there. When they get an update, let the family know, because we
Exactly.
know that many people will be at home, as the agents say, itching to hear an update, itching to hear what's going on.
Yeah.
Yeah.
Thank you, caller, for your question.
Now, I'm going to pass there and see how that they're going to see, because since I done there last month, as you all say, you all did some work, so I will pass and see.
So what I would advise you, caller, it's good that you would want to pass and see, but it's an accident and emergency department. That's when you come there, and Dr. Cruickshank will get more into the details.
Coming in when the place I standing outside and look, it's a big patient, the Elizabeth Fawcett.
And we welcome you anytime. But it's better you come down there when you need the service.
I am a heart patient. I have to go there every 6 to 8 months. My next appointment is the 8th of December, God's willing. Okay?
Yes.
Right.
Your next
Thank you
appointment
so
may
much.
not be in the A&E, but we welcome you all the same, caller.
Indeed.
Right.
And it's good to have you coming in.
I got my business up there, as I tell you earlier. So
Yeah.
I ain't got no quarrel. We just go on and deny it. So it's just like we done here. And I tell you, my granddaughter, she have this serious to deal with and so on. And that's all I was concerned about.
Got you. Thank you so much for your comments, your questions, and your well wishes as we make sure that we can deal with patients, family, and visitors
And
as they come
visitors,
into the
yes.
hospital and the A&E. Dr. Cruickshank,
Yes.
let's get into the triage system and the flow within
triage.
the AED.
And this system that is used internationally as well, in emergency rooms here, emergency rooms in the Caribbean, emergency rooms in other places. Let's get into
We are
it.
going to get into that very quickly after this caller on the line. Hopefully it's a quick question that we can answer. These things happen. Let's go, caller. Welcome to the Pulse Radio Show on Q100.7 FM, a production involving the Queen Elizabeth Hospital and our partners CBC. Welcome. What's
Good
your
morning.
question or comment? Good morning.
Hello,
Hi, good morning.
how are you?
I'm good. How are you doing?
How's the doctor?
The doctors are
We're
great.
great, thank you. Thanks for
Okay.
asking. Yes.
Okay, I have a question. I
Sure.
know that they have to be changed. This is not 1974, this is 2024. Back in the day when you go in the hospital, you see a nurse, and you will see this is Nurse Blackman or Nurse Green with a pin on her uniform. What happened to that? Because you go into the hospital, you see a nurse, you have to say, excuse me. I don't think that's very nice. Like I said, I know they have to be changed, but that is something that should not be changed. The nurses should still be wearing that pin that when you don't have to say, excuse me. You know what I'm
But
saying?
it's always good to say excuse me, to be honest. I
Yes,
like
but-
that. That's good manners and proper etiquette. I learned that as a child growing up.
All of us
When you
learned
ain't
that.
sure, you say excuse me, ma'am, or excuse me, nurse, and our officials normally wear their scrubs, and you have Dr. Cruickshank walking around in her white coat. So and normally they have IDs now, so it's not the pin. They have a little ID card around their neck hanging. So then you would see, because with the pin it may be too small to see who it is and what their name is, but with these bigger IDs now, you can actually identify who are the personnel manning the accident and emergency department, or just across the hospital in general. But continue, caller.
Everybody's supposed to be wearing theirs, and if that's the case,
Yeah, that is normally around their neck. That's how they have to get to traverse from area to area within the AED through these swipe passes that we have.
because I have been in one of these medical places, and I have seen a nurse take that ID that you were talking about that's hanging around her neck
Mm-hmm.
and turn the back to the front. I've seen that with my own two eyes already.
Mm.
So there has to be something that you can call them by name, Nurse Blackman or Nurse Green or Nurse Brown or Nurse. Excuse me is still a good thing to say.
Of course.
Because our parents teach us that way.
I'm 100% for that.
But I still think that you should be able to call a person by their name.
I know.
You know what I mean?
Personal touch.
Yeah.
And Dr. Cruickshank is actually going to speak about that. She's the head of the AED. Dr. Cruickshank?
Right. Cole, I do understand the challenge you have because a lot of staff members wear scrubs, and you may not be able to identify who is the doctor, who is the nurse, etc. So what we are hoping, the HR department is now going to be bringing in new ID cards where your profession is going to be bold and big on the ID card.
Lovely.
So that you can see the nurse, the doctor, the emergency room technician, and it's going to be on both sides of the ID card. So therefore, even if they flip it around, you'll be able to identify which staff member you're speaking to.
Absolutely.
You like that?
Absolutely.
I love that. I love that
And
response.
absolutely. And you know what? This program is great. This is a wonderful program, and I thank you guys for bringing it.
You're very, very welcome. I just want to let callers and
Have
our
a good
listeners,
day.
you as well,
Thank
my
you.
dear, have a good
Bye-bye.
day. I just want to let our listeners know you can also WhatsApp us. If you don't want to call, you can WhatsApp at 434-1007. 434-1007. And those call numbers again, 434-1007, 1007, or 434-1070. One more quick caller before we get into this triage system, because we want Barbadians to understand the common question that we get, FAQs. Why wait in the AED? Why wait for what may seem sometimes like an extended period? Good morning, caller. Welcome to the Pulse Radio Show. How can we help you?
Good morning, sir.
Good morning.
I have nothing but high praises for the QEH. I went there last year. I went to Fadu Crest and was transferred there. And apart from the grace of God and the workmanship of the doctors and nurses there, I'm still much, much better. And I just want to say thank you. It's a wonderful hospital. It's clean and tidy. All the staff, I'm telling you, from the orderlies back down to the cleaners, everybody is just really, really, really work together as a team. I want to encourage them to keep on doing that. And when I went to the A&E, I was transferred to a ward, but even there and then, everybody was like really, really good. So just keep on doing a good job. I went to a hospital in another country. It's called Queen Elizabeth II, Queen Elizabeth Central Hospital, and I say our hospital reflects the royalty, but that one surely doesn't. So we have a lot here, and people complain, and then to see that you don't have to pay for any almost. Well, I don't know about other things you gotta pay. You know, if you got a private ward, you pay, but you can go and get free medication. Like so much things are free. And we really, really, really have to thank God for this. Keep on doing what you're doing. You're doing a good job. My mother was hospitalized like 8 years ago, but she went to a private hospital first, and then again was transferred there. I had gone to Stanley Crest and they told me the best they can do for me is to send me to the QEH. So, and that's after paying a lot of money too. So I just want to thank, God for our QEH and the nurses and the doctors. I went and had an operation there, and again, it was like angels attending to me. They were no, I'm telling the truth.
I appreciate it.
I criticize a lot, but I'm telling you, we got a good hospital. We have a very, very good health scheme here. Believe me. So I just want to thank you all. And
thank you so much for your comments.
nothing but high praises for you all.
Thank you very much.
Every day, the most thing, nobody don't like waiting, but they're tough just to wait because according to the amount of people that are there, come on.
Yes. And
And
not
you
just
want
the
the
amount
best
of people,
result,
we're going to
yeah.
explain why as we go on. So I encourage you to stay with us because it's not.
Sure, of course, again,
that's
this
part of
is a
it.
very good program.
But we do, things happen that require time for the doctors to determine what's wrong with the patient, and they also start treatment. Sorry.
Yeah.
Well, I understand what
And
you're
so on.
saying.
So
Somebody
yes,
come
thank
with
you
a
for
cut
the
finger.
information.
If somebody come with a cut finger, somebody come with a gunshot wound, is that if they got to attend to the person with the gunshot wound first? Do you understand?
Yes,
So
and
people have to know these things.
I agree with you. And on that point, that's why we want to get Dr. Cruickshank talking about just how we operate in that regard with the
Right. So
triage system. So listen up, caller. We
I
have a
listen
lot
on
more
for
to come.
sure. It's a very good program. Keep it up.
Thank you very much, caller.
You're most welcome.
We appreciate the kudos. Dr.
Sure.
Cruickshank, so you heard the caller there mentioning he understands that someone comes in with a lesser urgent injury, and then someone comes in with a gunshot wound, and then you have to define gunshot wound to where, because if it's just a graze, it would be a less serious injury as well. But if it is to a vital organ,
Yes.
then our doctors and our medical team are really called into action to put attention to that category 1 or category 2 patient. So let's get into your operations and the triage system, how you're managing things there.
So thank you, Shane. So as Dr. Ria had said, we use a system called triage. And triage is really a French word, which means to sort. So when patients come, we sort them according to their medical condition and their urgency.
So those 60-something to 100 patients a day, you have to sort.
We have to sort them.
Okay.
And the system is called triage. And the system we use is called a CTAS, which is an acuity scale. And CTAS stands for the Canadian Triage and Acuity Scale. And we have 5 levels when we triage someone into the CTAS scale. So when they come in, of course, they will pass through security. They will pass through medical records to get their demographic data, front sheet written up. But they're going immediately to the screening or triage nurse. And obviously the triage nurse, from objective and subjective information, will put the patient into a CTAS score. And objective obviously is vital signs, blood pressure, pulse, etc. And subjective is speaking to the patient and getting the history from the patient. So from that, you get a CTAS score.
So that is why a patient has to talk to the nurse and tell them what's happening, but then also turn around and talk to the doctor. Because
Yes.
both persons need the information in the patient's words, which is always best.
Right. And so there is a repetition sometimes of the history
Yes.
to the triage nurse, to the doctor in the A&E, to the specialty,
Yes.
and even further when you
But
get...
that's important because medical conditions do not stay stagnant.
Correct.
They change over time.
Yes.
So in my role as a doctor, I know that a patient may tell you, well, this is how bad my pain is right now. And I may look back at what the triage nurse wrote and see, okay, the pain was worse then
Yes.
compared to now, so things are improving.
Right.
Or the opposite. So that repetition helps us to also paint a picture of what is going on with the patient.
Yes, because once you start treatment, you have to reassess.
You have to reassess.
Always reassessing.
Yes.
So
That's definitely the key word, the reassessing.
assessing. Yes.
I think that's the difference between, well, not difference. In primary care, they will reassess as well, but the interventions and the tests that are done can take much longer to get back. And because the patient is ill, you can't send them home to await the result. In primary care, if the patient is stable, you can have the person do the test, go home, and you call them back in a week or so with the result. But in the accident and emergency, these are the sickest people in the country.
Yes.
So their tests, to be fair to the patient and to practice good medicine and to have the best outcomes possible, this is why the doctors keep the patients in the A&E so that they can reassess based on results and interventions.
Yes. Before we
Okay.
go on to that, Ria, I wanted
Yes.
to just go through the CTAS
Sure,
levels
yes.
so that persons know
Yes.
when they come to the A&E,
Yes.
when they see the triage nurse, what the different levels, what the different CTAS scores are.
Right.
So obviously if you come in and you're given a CTAS score of 1, that means highest priority resuscitation. You have to go into the resuscitation room. All hands on deck to manage that patient.
That's when they say emergencies happening and all the doctors gone.
Yes.
Yes.
So you will hear on the overhead with all doctors, please report to the resuscitation or stat room.
Regardless of what
regardless
else
of
they're
what
doing.
you're doing. That's a
'Cause
category
that is
1.
the illest patient
patient at
in the
that point.
department.
Correct.
At that moment.
Yes.
Who needs critical and immediate care?
Correct.
Immediate.
I mean,
yes.
it is life or limb threatening.
Yes.
Right? So category 2 are what we call emergent. Their vital signs are abnormal and they have a high possibility of deteriorating rapidly. So they should be seen relatively quickly for a category 2, CTAS 2.
But after the category 1.
After the category 1s. Category 3, which is our most common are urgent. Their vital signs are normal, but they have the possibility of becoming unstable at any point in time. So they need to be seen, but not as urgently as the category 2s or the 1. 4s are less urgent, and they can wait 1 to 2 hours because they can be treated and stabilized, and they can wait. So those are category 4s, and they may not even necessarily have to be seen in the A&E.
Right.
We can refer them to the 24-hour clinic at Sir Winston Scott Polyclinic, which is our sister clinic.
Yes.
So we can refer them there, but if they need x-rays or any bloods, we tend to keep the category 4s.
Right.
And then the category 5s can wait because they are review patients. We have a review clinic Monday to Friday.
So that's happening as well.
That is happening as well, and the consultants run the review clinic,
Right.
and that might be from 8 to 11:12 in the morning. Consultants are running that clinic where we bring back patients to the A&E for the ones
To
that we are concerned to
reassess.
reassess
There we have that
to
word.
reassess. So if they were discharged, we don't want to send them back to their private or polyclinic doctor just yet. We bring them back to review clinic to review them because they may have gotten better or they may have gotten worse, and we now have to refer them to the specialty for admission. So there's always reassessing, always reassessing
always.
the patients.
Yes, on that note, let's pay some credit to our sponsors today, MedSafe Medical Supplies.
Of course, you're listening to the QEH radio show brought to you with the kind compliments of MedSafe Medical Supplies. And Shane, I've been also following, so I'm making my notes, especially for those who are attending the accident and emergency. You know, people tend to go there for a plethora of reasons, but you stressed on the word emergency, and
Yep.
I'm hoping that Dr. Cruickshank can also outline for some of us what is categorized as an emergency so that you can also help to alleviate the flow.
Indeed. And what the process that we are talking about, as Dr. Cruickshank has been explaining, is dictating that flow, how things flow in the accident and emergency department. So you heard Kimberly asking, just for the general public, strictly that flow. How do and you went through category 1 through 5, how that will dictate the flow. So
Yes.
people may not understand categories, but people all and she said it right there: accident and emergency, 2 keywords in the phrase, which is
The title.
the title of this
Of the
department.
department, yeah.
So you think about it, public. You're not an accident, and you may not have an emergency, but you are not feeling well, and that's what happens a lot of time. Those
Right.
people present there, as in most cases they should,
And
and they have the option to call PALS.
Yes, so they have the option to call pals, and it is totally understandable that when you're not feeling well, it feels like an emergency to you.
Of course.
You stump your toe, you're sure it broken, you think you're gonna die. That is an emergency for you, and we're not negating that at all. But when you do come to the accident and emergency for something that you're not feeling well, these categories help to objectively, as Dr. Cruickshank said, determine who is a more emergency than others. So we speak about urgency. She mentioned that. So urgency is a level under emergency.
Right.
If you're not sure if you're an emergency, you can call and ask a question. We provide that service. 536-4800.
536. Write it down. Write it down. 536.
That's your hospital pal.
4800. As Dr. Corbin Hart said, your
QH
hospital
pal.
pal. So you can call between what times, Dr. Corbin Hart?
9 a.m. to 9 p.m. Monday to Sunday. Except public holidays.
7 days a week except public holidays. You can get the information you need if you're feeling unwell. If your family member has a concern that you want to address as quickly as possible, we have a medical team manning that desk to give you the information you need.
Yeah.
But Dr. Cruickshank, the question always comes, and we see it in the media popping up from time to time. I remember one of the last articles spoke about a 7-day wait in accident and emergency, which was not the case, and which we had to respond to explain what would have happened in that situation. Not nearly a 7-day wait, but there was treatment throughout that process. There was correspondence throughout that process. The patient was being assessed and addressed throughout that process.
I can give a little summary on this, and then Dr. Cruickshank will expand.
Yes, but one thing before I let you do that, Dr. Corbin Hart, I want people to always remember there will be positive outcomes, but in worst cases, there are negative outcomes. Everything cannot. This is life that we're living. Yes.
In the accident.
And our medical team always does the best that they can to address the patients as they present.
Yes.
Some patients come at a latter stage when they're on death's door. And that can be trending towards a negative outcome because really and truly the numbers are not in your favor. And that's why it's always good to get as much information as you can and get that information to us so that we can help to guide the process through accident and emergency, or if needed, in another sister healthcare institution where you may be better served and you would not have to wait. But we're going to get into those wait times. You had a summary, Dr. Corbin Hart.
Yeah, so the summary of the age-old question that we hear often. My relative is in A&E for 5 days, 4 days, 7 days, whatever the case is, or they're waiting in A&E for that time. I always explain that I guarantee you they're not waiting for 7 days with nothing happening. Guarantee you 100%. What happens is that in that time, they would have seen the triage nurse. They may have waited some hours to see the A&E doctor. And treatment is started as early as with the triage nurse. So if a patient is obviously dehydrated, the triage nurse will put up drips, as Bajans call it, and start fluid. So that by the time the doctor sees the patient, they can reassess how has that fluid helped. Has it helped to the point where the person is no longer dehydrated, or is it not yet enough? So something has started. When the doctor sees them, they do further tests, further investigations as well. They then review, because our aim is not to admit everyone. We don't want to separate people from their relatives. It has been proven that you respond better and you improve better when you're in your usual surroundings with your usual caregivers and people and so on. So our aim is not to admit persons. We do our best to see, can we get you treated so that you can go home? But if that doesn't work, yes, of course, we will admit you. I always give the example that heart attacks, for example, like many other conditions, require a trend in what results are showing. What do I mean by trend? We can't just take one result and say this is definitely a heart attack. Well, sometimes you can, but there are other times where you can't just take one result. It's kind of a gray area, and you have to repeat that test. The normal medical guidelines require that test be repeated in about 6 to 8 hours, and then again in another 6 to 8 hours, and sometimes again along with an ECG before you can determine, yes, this is a heart attack that needs admission, or no, this was not a heart attack.
But believe
and
you me,
during that time, you're getting preliminary treatment in case it is a heart attack. And that's physical time that we cannot cut down on. We cannot discharge the patient and we cannot admit them to the ward because we don't have a diagnosis. So that it's active treatment that's happening. So
well, before we go to Dr. Cruickshank, I'll let Dr. Cruickshank respond to these callers. We know you have callers waiting with many questions, and Dr. Cruickshank is here to answer those questions for you. She is the head of the Accident and Emergency Department. Welcome, caller, to the Pulse Radio Show. What's your question or comment?
Hi, good morning.
Morning.
My pulse was actually racing away, so I hope I could get good answers.
Yes.
Yes. Let's go back 25 years ago.
Well,
Yeah.
I was nearly not born, but go ahead.
Yeah, great. No, why I said that? I've taken my son because he was an asthmatic. So you know how he used to be at that time.
Right.
Say the main thing, turn to the right, and you go there and get pneumonize, right? So that's the time waiting thing. So I would go in there and sit and wait with him. I wanted to call in to answer the question, but you all did answer the question before I get to ask the question, right? And this is about how many persons could come in and be with a patient, right? And I wanted to find out why it is husband and wife, father and mother can't be together with the child. Reason why I'm asking that, because the mother might not be able to watch the child go through whatever sickness the person brings the child there for, and the father there may comfort the mother. So why put out one and got one outside sitting down, waiting anxiously to get in for she to come out to go in? I know you got that come out going. That was a mind bothering something to me, right? If it was only me, the husband, I say, I only want the wife there, not a problem. But since I have a child, I wonder why the two parents to comfort one another can't be at the bedside.
Okay.
I know you answered and save a space, so I wondering why we can't do something about that.
So, caller, I'm going to confirm what you just said. Now, the A&E, as Dr. Corbin Hart said, is dynamic, and there are times when we have patient surges. If we are in a patient surge where we have 40, 50, and 60 patients in the A&E, we allow one parent to be with the child and we exchange. If, however, it's a comfortable day and we probably have like 20 patients in the A&E, we do allow both mother and father, because we encourage mother and father to be with the child. We have a pediatric room, which is room 7, and we do allow mother and father to be in the pediatric room with the child, and in the asthma bay we allow mother and father to be in the child. But if it is quite congested, we have to alternate and exchange the mother and father. But I do agree with you totally, mother and father should be with the child or the infant.
Okay, thank you very much. And as I said, that was 25 years ago. I haven't even used the A&E for so long, and thank God, God is helping me.
That's a good thing.
Right, but if I I do go 3 FMH or something like that, instead of coming down there and I can't say taking up people time.
No.
Ain't all people that have got the money. I ain't saying that I got the money. It's just that I prefer to go some place that I know that I can get through and I can be comfortable and I can get back home. That's the object. You understand? But in the case that person don't have money, they're gonna run down there to know that it's just a funny little sickness that you don't need to be down there. You could bear it out, but because people are so frightened in sickness, when you get sick, you're frightened. Yeah. So you're thinking the worst thing. You understand? So I need to see a doctor. And coming on the point of the doctors, the first person you see is a nurse. And for me, I believe a nurse is a doctor because the nurse gets all the information.
Yes.
The only thing the nurse can do is prescribe the medicine for you or the doses. But I believe a nurse is a doctor.
And we have some nurses that
and we do
they do have knowledge. They definitely do.
We are hoping to get nurse practitioners in the A&E. We do have one who's come back from training, and we're looking forward to have a nurse practitioner who can write prescriptions but has to be vetted by the doctor. So we are moving forward in the
because if I in that field, I as a nurse and I seeing that the symptoms come in, I go and tell the doctor the symptoms and the doctor say this is for that. You mean to tell me I can't copy? Why I know the symptoms, you tell me, oh, he got the flu, oh, he got diarrhea, he got dengue. You understand? Because you're seeing the symptoms, you know the symptoms, and you could go ahead with that. That's for persons that are really interested in their jobs. You understand?
Indeed.
Yes.
Caller, thank you so much for your comments and questions, bringing us from 25 years back to 2024 where we are now. Appreciate your time. Next, we have another caller on the line. Good morning, caller. Welcome to the Pulse Radio Show. What's your question or comment?
Hi, good morning, Sean. How are you doing?
I'm good. How are you?
Oh, God, that's wonderful. With great power comes great responsibility, and you're responsible for this call. I want to thank Sorry, excuse me. I want to thank the good doctor for coming on this morning. Let me thank the team. This is really a great initiative. I have 3 questions. The first question has to do with the accident and emergency, and in case of the department in terms of repeat visitors. Can you have an automatic triage system where the nurse or the doctor, obviously in the future the nursing practitioner knows what they're doing, and they would have dealt with the case before and they have to do the same thing again? Not only repeat visitors, but repeat visitors with the same thing, with the same malady, with the same injury. Obviously, they would have done almost the same thing to get that. So it's just the same thing over and over again. So I was just wondering if it can be even faster in that way to get the bottlenecks from happening, to get the system working even faster. My second question has to do with the fact of the aspect of the fact that the accident and emergency is the largest organ in the hospital. Of course, a lot of people believe that the largest organ is the skin, but it is indeed the blood, the accident and emergency, because the blood is just an organ that is volume in terms of liquid, so it is actually the biggest. And in terms of that metaphor, in terms of the accident and emergency department, for tourists coming, for people coming, obviously you would have dealt with the workout and we would have dealt with this topic last week, Shane, and I mean thank you for that. But for the irregulars, the tourists, the people who are coming off the cruise ships, the people who are coming off the planes, what is done in those special circumstances for the accident and emergency at that time, so that you're not having as many people happening? And I would like to add to that question the aspect of what would have happened this past weekend with the failure of the phone system. What is put in place in these special circumstances happening, obviously, so that there's not because I'm trying to focus on the fact that there's always people coming in, and you always have to try to get this zero capacity or no capacity, so that you're always either tending to people or finished tending to them.
Right.
My final question has to do with the fact. Thank you. My final question has to do with the fact of this know that Barbados is going green, and in the future there's going to be a lot more accidents in terms of electricity. There are a lot more people who are going to be shocked. There are a lot more people who are going to be who are going to face a lot of injuries based on electricity.
Caller, hold tight, because we want to answer as many questions as you have asked, and we can't predict the future. So I'll let you hold on that one while we answer the first 3 questions for you very quickly, because there are a number of callers as well. So we want to get some answers to you, and Dr. Cruickshank has those answers here for your first 3 questions. You spoke about frequent flyers first, so let's start there.
Okay, so yes, we have patients who we do term medically as frequent flyers. They come with these same medical conditions, maybe several days in a week. Mm-hmm. But we always have to triage them, because we have to be careful that they're not the boy crying wolf, and something sinister is not occurring with them on this presentation. Yes. So although, yes, we know them, it is very easy to discard them and say, oh, it's John or Jane again, but we cannot take that chance.
Because John or Jane may actually be
have something
a heart attack
this time,
as opposed to just reflux causing the chest pain.
Correct.
Yes,
so we do have to we have to triage, we have to reassess, and don't miss any steps. Understood. And then go through again thoroughly. You also have to consider if there's a psychological problem going on here, that they keep on coming back with the same complaint, because there may be an underlying root cause that they're coming back. A lot of the elderly, they may be home alone, so they come to the A&E for that comfort and for that shelter and reassurance. Yes. So we have to look at the totality of the patient and see what is the cause why they're coming back. So we don't want to assume it's the same problem.
Can't assume in medicine.
Exactly, frequent flyers.
Definitely.
With respect to World Cup, our team has been working assiduously since last year to plan for World Cup now. So we know our engineering head, which is Miss Agubu, has brought everything. We have the Harrison Point, which has now stood up.
Yes.
And it's a 20-bed capacity, so that if we have to have a surge of patients at the QEH, we would decant to the Harrison Point. Right. With respect to the A&E, we have asked HR for more staff for World Cup and also going into crop over, so that we are prepared for the
As
surgeries
best
as
possible.
best as we
You just
can.
never know. You don't know if
You
a
don't
thousand
know.
patients will come or
Exactly.
two.
So you always have to fly in
Understood.
front of the plane when you manage the A&E. You cannot fly in or behind, or you're going to be left or behind.
You're doing a
So-
great job,
Yes,
Dr. Cruickshank.
I like.
So
And then for the patients, well, I guess that will also deal with those people, the influx of people coming in for World Cup and then for crop over.
Correct.
And many of them tourists.
Yes.
The caller asks, how do we manage tourists? And I believe it's in
the
a similar
same.
fashion.
It is the same way, but visitors have to pay because they're not nationals and they don't get their health care free.
Right.
So we would always
So
contact
that's the difference.
the
It's corporate business unit.
corporate business
of the
unit of the
QEH.
QEH. When we have a visitor,
Yeah.
a visitor, we have a sheet which outlines all the treatment that they are receiving, and then they are billed accordingly.
Yeah.
So
Understood.
same management, but they now have to pay.
Yeah, and to your last question, caller, the phone systems were indeed down over the weekend. We had a PBX reboot on the Friday, which was
Regular
from the
maintenance.
Digicel side, regular maintenance. On Saturday, Flow, they went down for a couple hours, but they worked with us and we were able to quickly get back online so that we were able to again accept those calls coming into across the hospital, because we have of course the PBX, but then we have some other central numbers that people need to get, like the ambulance, 511, and then the numbers for accident and emergency. There are numbers for A&E as well that we will share with you, so that when you need to, that you can call so that you can be properly assessed. And we always say to you, call your hospital pal, 536-4800. We had a question coming in over WhatsApp, where a caller or a listener asks, good day, when it comes to A&E, what about blood supply? How is that procedure going when we need blood? Which types? Are we doing enough? Dr. Cruickshank.
Right. So obviously, as we know, the A&E is dependent on all the services of the hospital, and the lab, in particular hematology, in particular blood bank, is a section of the hospital that we depend heavily. So if we have a multiple trauma patient who needs blood, we can take their blood sample quickly, we send it up to the lab to get group and cross matched, and they will send back the appropriate blood grouping for us to transfuse the patient. Or we may have a patient who's anemic and needs blood. Once
Meaning
again,
their blood count is low.
low. Once again, we depend heavily on the blood bank in the QEH, in the lab, to supply that appropriate blood group for us.
Understood.
So we are always ready if we do have to do a blood
blood comes
transfusion
pretty
in the
quickly.
A&E. And that caller said 25 years ago, when I was joining A&E, we didn't do blood transfusions in the A&E. Now in 2024, that's normal for
That's
us.
normal,
We do blood
'cause
transfusions.
From my time,
Exactly.
that's normal for
That's
me.
normal. We do everything now in the A&E.
I'll speak about a part quickly that's commonly misunderstood, and I think this person was alluding to it, where they asked what types of blood are needed.
Right.
This is a question that in patient relations we get a lot, and also when persons make complaints, they would say, 4 persons went and donated blood, but then my relative didn't get blood. Or, and they would say, but why is that? So here's the thing. The blood bank works literally like a bank, where persons put in and other persons get out.
Withdraw.
Exactly. Some people deposit blood to the blood collecting sector, and we always encourage persons to donate blood on a regular basis, not just when a relative is ill, but other persons get out. I may donate blood and I may be type A. Dr. Cruickshank may come in and need blood urgently, and she may be type B, right? AB, or another type other than me. And then you may come in, Shane, knock on wood, and then you may need A. I may have donated on behalf of Dr. Cruickshank, but because my blood does not match hers, they would give you, Shane, my blood, and the person who donates on your behalf may give another patient, and that's how it goes. So the group and cross match that Dr. Cruickshank spoke about is where we send a sample of the person's blood to the lab so that we get a good match of blood for that person. But because of how a bank works, you still need donors.
Yep.
You still need donors. People even ask, what happens when I get blood donated prior to my surgery? that blood goes to an emergency case where the relatives wouldn't have had time.
And on that point, we do have a blood drive coming up June the 14th at the National Blood Collecting Center, so you can look out for that. And we'll tell you a bit more about that when we wrap up the show. Good morning, caller. This is our last caller for the morning. Time flies so quickly here on the Pulse Radio Show. The Pulse is racing. Good morning, caller. Welcome.
I said good morning.
Hi, how you doing?
I'm fine, thank you. A quick question. How long do you wait for a discharge paper from the A&E?
Dr. Cruickshank?
Yeah. Why is patients being discharged and not have their discharge summary right away or a week after?
Okay.
Okay, I'm not really understanding that, because when you're seen in the A&E, you are either going to be discharged or admitted. If you're discharged, the doctor who is managing you will then write a discharge summary to your primary healthcare physician. So I'm not sure why you said that you had to come back for the discharge summary. Could you give me a little bit more information there, caller?
Mom visited during March. She was discharged, and the doctor said she would write the discharge paper and I have to come back for it.
Okay.
From March to now, my mom did not get the discharge paper, so she's unable to go back to her general practitioner to have a follow-up.
Okay.
I was calling the doctor on and off, and I still did not get it. I was told the doctor is back from holiday Friday, which is Friday was the 7th, 6th. So up to now, I'm still waiting for the discharge summary.
All right.
Is there any way you can help me to get it?
I think I know the case you're referring to, and to my being informed, that discharge summary was written, but I think it was misplaced. And the doctor rewrote it again, and she will write another one for you. That doctor was on holiday, and she is back now. And I have spoken to her to write that discharge summary. If you are the same caller that I think I am.
You sound, yes, please.
Yeah, so that will be written for you. That doctor has been informed, and she will write it for you. And the patient relation rep will be the one we would give that discharge summary to you, and they will call you.
Okay, so I can wait for a call.
Yes, and if you have any problems, you're free to call
the
hospital pals.
They're your pals.
536-4800. You got that number,
No
caller?
problem.
536-4800. So when you call your hospital pal, you'll get that information about how to
Okay, and I
collect
must say, A&E has improved. Everything is great up there. You folks are doing a wonderful job.
Thank you so
and
much.
I heard this program last week, and I say, wow, it's a very good program.
Thank you. Thank you very much.
We appreciate your caller, and I'm glad that you could get your problem solved right here with us.
Yes,
on the
thank
Pulse
you.
Radio Show. We
Have a
we
great
hope we
day.
can do better by you going forward.
Yes, once I get the report, that's okay with me. Thank
Sweet.
you.
We'll make that happen. Thank you, caller.
All right, have a beautiful day.
Have a
Bye-bye.
good day. So as we wrap up today's show, Dr. Cruickshank, I want to give you and Dr. Corbin Hart some final words, some final thoughts that we can share with the public in summary about how the A&E operates now. We're looking to a brighter future. We have an expanded department. It offers a whole lot more services, and that's why you will wait longer getting treatment and other services in the A&E. And new services are to come as well.
Yes, the new CEO has some plans in store for us, and we're looking forward to see what can happen with the new A&E and those new plans.
Interesting stuff coming ahead. Any final thoughts, Dr. Corbin Hart?
Definitely that accident and emergency is it really does a lot to be able to pull persons back from death's door, as you said, to as best they can get them. It does take time. The tests take time to come back, so you have accurate reporting. They take time on the machines, the interventions and everything, so it does take time.
Very quickly, a fun fact. Your fun fact for today, Dr. Corbin Hart?
I think we can pull our fun fact from Dr. Cruickshank that the accident and emergency sees between 66 and 100 persons per day, and that by seeing we mean see, treat, do interventions, do procedures, refer, discharge. Everything is happening, and that's a lot in a day.
And when you do that multiplication, you can do the math. 365 days a year.
And giving us 24,000 patients a year.
That I think is more than that, because if I do the math, and how much is it?
100 a day.
100 by that's 36,500.
Right.
Very quickly, next week we'll be here. You know the time, 11 a.m. to 12 p.m. till midday. we'll be talking about complaints and compliments, and also some advancements in transplant. We have some our head of the
clinical risk
management unit, and she was managing
Beckles-Hackett.
She was managing the huddle this morning.
Yes.
That drink didn't work for me in terms of the caffeine. My mind is still full. We'll also have Dr. Margaret O'Shea. She's one of the leads on transplant at the Queen Elizabeth Hospital. Thank you for being with us. Of course, a big thank you to Q100.7 FM, our new home. This has been the Pulse Radio Show, Episode 2. See you next week for Episode 3.
Every Monday at 11 a.m., learn about how the Queen Elizabeth Hospital works and how to make it work for you on Q. From the A&E to the ICU, NCDs to CPR, the QEH Pulse Radio Show is about your hospital and your health. Join Communications Specialist Shane Seeley, Patient Relations Manager Dr. Rhea Corbin-Hart, and specially invited medical professionals as they provide vital health information, answer your questions, and address your concerns live. The QEH Pulse Radio Show, every Monday from 11 a.m. until noon on Q 100.7 FM. The QEH connects with you on Q.